صباح الخير يا شباب. الله يعطيكم العافية. بنكمل موضوع البيدياتريك diseases، وموضوعنا اليوم عن الكومن pediatric illnesses، يعني ايش هي اكثر الامراض شيوعا. But before that, I would like to go with you into certain counseling or communication skills needed for how to deal with young children. Especially for us, it's important as pharmacists to know how to administer medications to children. So a lot of misunderstanding or miscommunication normally parents they do, or family. So I just wanted to share with you some of these recommendations or advices how to best administer medication to children. So when we talk about administration of oral medications, for example, to a young children or infant, normally we require two adults to take care of that. We need to avoid errors. We need to avoid harm to the infant. For example, if you see in this picture on the upper panel here, so you will see four hands, which means two people are handling this infant. They want to give him an eye drop. So you need to somebody to kind of fix the arms and the legs. Then the next person or the second person will instill the eye drops in the eye. So one adult gently to restrain the child, but don't to break the bones, of course. And the other one will rapidly and accurately administer the medication. But if there's only one adult available to administer a drug, for example, you want to give a dropper in the mouth, an oral solution or oral medication, then what they can do is try to restrain arms and legs of the child in a swaddling blanket, for example, using a blanket as you see in the picture here. So you kind of use this blanket to restrain the legs and the hands of the baby. So this way you will have better control over him, especially if using liquid formulations in the mouth or something like that. So if using also liquids, you need to be careful about measuring the volume of that liquid. And normally it's advised, if you see here in the picture, where is the best place to put that dropper, for example, or syringe, of course, with no needle. In the mouth, the best place is to give it in the back cheek. So in the cheek, stick it to the wall of the mouth, in the back of the cheek, so you guarantee that it's gonna go down into the digestive system with no problems. And the other also recommendation, I know a lot of people, they use whatever spoon or tablespoon or teaspoon available to them and take it just, whatever that volume, they assume it's 5 milliliters, but you never know. Different sizes are available, but the best thing is used to measuring cup or a syringe that's normally provided with the medication. If it's not available with the medication, just go ahead and buy one. Normally in the pharmacy, you can give them something like a syringe or something to measure the volume of the drug. Some children, they might also be able to use tablets. Normally, if they are 5 to 8 years of old, they can start eating, taking tablets. But sometimes if they can't, the other alternative is to crush that tablet or capsule contents, maybe mixed in small amounts of food. And again, we have to be careful about the dosage form or the solid dosage form. If it's a tablet or a capsule, is it film coated or is it sustained release or it's long acting? In this case, we can't crush it. So you need to be careful about what is the formulation of that drug. In general, if they have tablets, let's say you give them amoxicillin capsules, for example, that's fine. So look at the volume also. You give it to the child. What is the importance of that volume? Sometimes you give it with syrup, ice cream, jelly, applesauce, chocolate pudding, or something like that. So you can make it palatable to the child. And dilution in entire milk, especially for those who are on infant milk or formula, it's not recommended to dilute it in the full meal. But sometimes maybe the full meal might be, let's say, 100 milliliters or 150, or it's not recommended, but you can take 10 to 15 milliliters of that juice or milk or formula and mix the drug with that. So the reason for that is trying to avoid drug-food interaction, especially if you mix it with dairy products. And you will do kind of trying to avoid the interaction in this scenario. So how do we use otic, nasal, and ophthalmic drugs in children? So normally the administration method in this patient population is different from adults. For example, in otic medications, you need to pull the auricle of the ear down and out. So you put it down and out, then you stick the dropper inside. And older children, on the opposite, or on the other hand, normally they should have the auricle of the ear held up and back. Straighten the ear canal, so this way you can instill the drops inside the ear. So there is differences. Again, I want you to pay attention to this, because the way we administer medication, these are simple things you can teach it to people when you work in a pharmacy. What is the best way? Sometimes people, they are worried about their children. They pay a costly medication. They pay a lot of money for that medication, but ultimately improvement is really slow. Or a good portion of the drug is not getting inside the ear, in the ear of the patient. Number two, nasal medications. Nasal medications, you need to position the infant or the toddler with their head lower than the rest of the body. So think about the gravity, and you need something to stick inside the nose. So the best way is put the child on a bed and let the head below the level of the body. Then you can disperse or instill the drops. This will help dispersing the medication and get better absorption into the nasal cavity. The third thing about ophthalmic medications. Ophthalmic medications position the infant again, similar to what we have done in the nasal, and avoid injury to the eye caused by sudden movement. So you need to be very careful not to injure the eye of the patient. So again, this is the way we use it to instill drops. As you see here, we have 4 hands, which means 2 people. They need to restrain the movement of the child. Somebody is holding the legs, and somebody is holding the hands, and the next person is doing the eye drops for that patient. Now we'll start with the first common disease, and some of these diseases you might taken these with OTC drugs or other courses, but we will focus on simple things related to the best treatment options for all of these. They are very simple. So the first one is diaper rash. What is the etiology of diaper rash? I know a lot of you, they know what is diaper rash and what is the etiology for that. Normally we have inflammation in the skin, especially in the diaper area in children, due to chemical irritants, for example, like laundry detergents, soaps, medications, lotions they use on their skin. They tend to cause irritation, friction in that area, sometimes bacterial infection in the area, skin wetness. Wetness is kind of, most of it is wet. The skin is wet for long periods of time. The pH of the skin, or the preparations that we apply to that area. The next one is overhydration of the skin. So if you feel sweating, for example, those children, they don't get exposed to fresh air, to dry. So permeability of low molecular weight compounds, and normally exacerbates the effect of a friction. So that's what happens, especially in the summertime, when they have more overhydration of the skin happens. So they will have a composite effect of friction and this overhydration. The diaper itself also sometimes might be allergic to diaper itself, the substance that's made of. And the other thing, if they have the plastic pants or plastic lining or part of the diapers, I know some of them, they are maybe made of a plastic. That plastic is really very bad because it does not allow good air circulation. We need good air circulation in order for the skin to kind of get dry a little bit. We don't need it to be very wet, not very dry, by the way. So the clinical presentation, 4 clinical presentations of dermatitis associated with diaper rash, a mild scaling rash in the perianal area. Number 2, a sharply demarcating confluent erythema. That erythema very red, تسلخات بعض الأحيان في هذه المنطقة, ulceration, تقرح, distributed through the diaper area. بتطلع عليها بتشوف فقط في منطقة الدايبر area. يعني ممكن تمتد شوي. The skin itself, a beefy red confluent. Confluent, it means covering the whole thing, covering the whole place. It's not like very small dots or very small points. It's kind of confluent, affecting the whole area with satellite lesions, satellite remote, بعيد شوي, these regions or lesions, sorry, visculopostular lesions and diffuse involvement of the genitalia. Sometimes they get affected because of the fluid, of course. So a presence of a rash for longer than 3 days, that's very painful. The child keep crying. It's very annoying. Therefore, we need to be very careful about that. Number 3, diffuse involvement. We talked about it in the genitalia and inguinal fold. The treatment for most of these, it depends on the reason, of course. So we have to be cognizant about what medication do we need to use. Most of the diaper rash medications normally have antifungal, like 1% clotrimazole or 2% miconazole cream, normally applied to the inflamed area 4 times daily until the condition is resolved. Or alternatively, you might use nystatin. And by the way, nystatin is also available as oral form for oral thrush or oral candida. So this is an ointment where you can apply it, but it's not as effective as the upper ones, the imidazole antifungals, because of the resistance. Sometimes some of the kinds of candida species, they are resistant to this nystatin. The other measures that normally the mother or the caregiver for that child should be careful about is removal of stool and urine from the diaper area by gentle rinsing with a plain water and more frequent diaper changes. And that's what happened, unfortunately, in a lot of kids, especially in the summertime. They just leave the diaper for a long time, which may aggravate the problem. So therefore, frequent changing of the diaper also help to alleviate diaper rash. The worst thing is when they also use the wipes which contain alcohol. Very stinging alcohol will sting the baby skin, irritant to the skin, causing more pain, especially if it's kind of you have ulcers. It will be very painful to the child. Therefore, sometimes you apply a protective agent like zinc oxide, petrolatum. They are good. Like there's a cream called Destin. Can be applied with each diaper change to create a barrier. That barrier will protect the skin from moisture. It kind of will seal the area and protect against moisture and other irritants to the skin. People, they might use powder protective agents like cornstarch and talc to minimize the friction in the area. Especially, it's really very painful to the child. But the problem with this powder is you need to be careful about these chemicals from inhalation, especially if you apply them close to the nose or the mouth of the child. When you apply them, there is a chance of getting this into the uh, baby. It might lead to chemical pneumonia. So sometimes we might use cortisones, but be careful about the concentration. So low potency, non-fluorinated topical corticosteroids such as zero point 0.5 or 1% hydrocortisone twice daily, but for no longer than 2 weeks when severe inflammation is present. So we need to be very careful. Try to limit the area as much as possible. The quantity you apply and the duration should not be for a long period of time. Any questions about diaper rash? If no questions, I'll move to the next disease, which is very common in children, fever. Fever, I know most of you, you know the normal body temperature. Normally it varies through the day, peaking in the late afternoon or early evening. That's the highest temperature normally in the body. So there's normal fluctuation. There are 4 or 5 different methods we can measure body temperature with. The first one, which is the most reliable in infants less than 3 months, is the rectal. So you have a thermometer in the rectal area. So the temperature over there, we need to check what is the normal range for each one, or the normal reading. Typically in the rectal, it's 0.3 to 0.6 degrees Celsius more than the oral. So again, which method? We have to decide it or determine which method we are following, then the corresponding reading for each route. If you take it orally, it's not appropriate for children below 3 years because they are not cooperative. You need to stick the thermometer inside their mouth. They can't close their mouth on the thermometer, or there is some hazard with that. Axillary, under the armpit, about 0.3 to 0.6 less than the oral temperature. Fever, the axillary temperature is more than 37.5 or 99.5 degrees F. Temporal, in the head, tympanically, normally it's more than the oral body temperature by 0.3 to 0.6 degrees. Again, you need to know the differences in temperature between each method of getting body temperature through these methods. Now, if the child's age is less than 1 year old with fever, we need to investigate what is the reason for that elevation in body temperature. Always there is some underlying reason for that. So the best thing, if the fever is really high and you need to do the right thing, blood culture and urinalysis. The blood culture, you will check for if there is any bacterial infection. Urinalysis, to check if there is any infection also or white blood cells in urine. Therefore, while the culture, I know it takes time to get the results, 1 or 2 days, then while you are waiting, you can start using empiric antibiotic treatment. Normally, you give a broad spectrum because you don't know. After you take the sample or the culture, you immediately initiate antibiotic therapy, empiric treatment, normally with a broad spectrum antibiotic, because you need to cover everything until you get the results. Then you need to either to continue with the same antibiotic if it's susceptible, or use a more powerful drug. Now, we have 3 conditions. Sometimes if fever is accompanied by bacteremia, this is the risk that we normally kind of worried about, especially if the child is 3 to 36 months old, if the temperature 39 or more, and the white blood cells either too low or too high, between 5 and 15,000 per microliter. So this way, you need to be very careful about or think about the risk of bacteremia. If the child or the body temperature, sorry, is more than 41 degrees of any age, this is really high, then you need to evaluate for two things. The first thing that should hit your mind is bacteria. There is bacterial infection. There is bacteria in the blood. The second factor, because it's too high as a body temperature, think about possible meningitis. So what you need to do, ask for a blood culture. Meningitis, normally we do a lumbar puncture, take a cerebrospinal fluid and urinalysis. Chest radiography to see if there is any effusion or chest infection in this child or patient. And this applies, by the way, on adults and children, of course. Sometimes due to fever, we have what they call it febrile seizure. About 2 to 4% of children 6 months to 5 years of age, they have temperature elevation more than 38 degrees Celsius. The reason is unknown. Some studies, they believe that it might be due to genetic predisposition. Why it happens in certain children, only 2 to 4% of those children. Why does it happen? Maybe genetic thing. They have more genetic predisposition compared to others. And we have two types of febrile seizures, simple and complex. The simple, usually it lasts for a short period of time. It's like 15 minutes. And it doesn't have significant focal features. The complex, on the other hand, it has a longer duration, occurs in series episodes that are associated with focal changes. We all know the treatment for fever. Normally, acetaminophen is the first choice. Normally, it's the number one or the first line drug in children. It's the most common antipyretic agent used in children. Remember this dose, 10 to 15 milligram per kg per dose, administered every 4 to 6 hours as needed to a maximum of 75. In any scenario, in any case, don't exceed the 75 milligram per kg per 24 hours. And again, I will mention that again, per 24 hours. A day is not from 8 p.m. until 8 p.m. or midnight. A day is 24 hours. So you need to be careful not to exceed that 75. A lot of studies, when you read the chapter, you will see a lot of studies, they have medication errors in the hospitals. They exceed the dose without knowing, either by giving it during short periods of time or exceeding that 75 milligram per kg in children. Therefore, it's really important to avoid any overdose, avoid medication errors. We know the consequences of exceeding the dose with paracetamol or acetaminophen is liver impairment. The liver injury is the most common side effect. Although it's very safe, paracetamol, acetaminophen, but again, if more than the allowed doses, it might cause liver injury. The next antipyretic we normally use, it's pretty common, maybe number 2 is the ibuprofen, liquid for children or suspension. Ibuprofen normally in the range of 5 to 10 milligram per kg per dose. You give it orally every 6 to 8 hours, PRN, to a maximum of 40. Also, don't exceed that 40 milligram per kg. As effective as acetaminophen as antipyretic and almost similar in safety. So they are comparable if you give acetaminophen or ibuprofen. So some studies, they sometimes said ibuprofen may cause renal failure. So the risk of renal impairment after ibuprofen appears to be greater in children. They have special conditions. First, if they are dehydrated, then it gets excreted through kidney and there is not enough fluid to be excreted. Therefore, you need to rehydrate the patient. If they have an underlying cardiovascular or renal disease, if they are using other nephrotoxic drugs, especially in children more than 6 months of age. So some data, sometimes you will hear some physicians even, sometimes they have a combination of both acetaminophen and ibuprofen. They give them, for example, acetaminophen every 4 to 6 hours and ibuprofen every 6 to 8 hours. Maybe more effective in reducing time with fever in the first 24 hours, especially if it's really high. You could combine both, but don't use them for a long period of time. So again, that combination, it's very efficacious if it's under medical supervision, especially the first day. But again, using two medications, you will have associated to medication errors. When you have, it's very possible to have the dose elevated in one of these medications. So recent data again suggests an increase recent data suggests an increase of acute kidney injury may occur with this combination. Aspirin therapy is not recommended for patients, young patients, especially if you know it might cause Reye syndrome in children, in adolescents with chickenpox, gastroenteritis, or respiratory viral infections because of the link to Reye syndrome, which might affect the development of the central. Now, the other disease is the common cold. We are in the middle of coronavirus now, and a lot of people are talking about the common cold. Don't get confused between this common cold is going to happen. It's happening in the past, and still is happening now, and it's going to happen in the future. The common cold is the viral upper respiratory infection. So normally, on average, studies found a child, especially preschool children. Preschool is like 3, 4, 5 years. This is preschool 5 years. Let's say about 6 to 8 colds per year, especially in the winter time. So that's the average. And they normally present with a sore throat, nasal congestion, rhinorrhea, sneezing, cough, irritability. So if you come with these symptoms nowadays, so people, they will be run away from you. They will get confused about coronavirus. The treatment for colds, normally we have measures before we go to medication, especially in young children, in infants. A cool mist humidifier. A cool mist, sometimes we have warm mist and cool mist. The cool mist is kind of a cold water vapor. The warm mist is kind of hot water vapor. That's instrument you hook it up with the power and will give you vapor or moisture in the air. It's supposed to decrease irritation in the upper respiratory tract. A lot of us, they do water vapor in the winter time. In addition, some people, it's recommended, by the way, to use saline nasal drops or nasal spray. Follow up with bulb suctioning. Bulb suctioning, you instill that bulb inside the nose of the infant to clear the nasal passageways. So this way, you will take out the mucus from the noses of the child, especially before feeding, because if they are blocked, then they can't breathe and eat at the same time, especially if they are breathing from the mouth, for those who are 6 months and younger. What about decongestants in common cold and cough? Decongestant, they are not appropriate for infants, especially if they are less than 2 years of age. So when you work in a pharmacy, don't give decongestant to children less than 2 years of age. And even sometimes they said even 6 years. They are not safe until 6 years. Phenylephrine is preferred. If it's a must to give a decongestant, then you have preferences now. You have phenylephrine is preferred over oxymetazoline or xylometazoline in children less than 6 years of age due to lower toxicity profile. Normally, these are anticholinergic side effects like sedation, convulsions, insomnia, and may cause coma if you exceed the dose. Some cold and cough preparations, they have antihistamines, antitussives, guaifenesin. They are just have no help. They're just taking them for nothing. Maybe just for the taste or placebo effect. They don't have any action in that. Antihistamines, they are good for allergy if they have seasonal allergy. Rhinitis due to seasonal allergy, but not rhinitis due to common cold. They are not effective. Antitussive, they will stop dry cough, but in this situation, most of the common cold, they have mucus or wet cough. So it's not going to work. Guaifenesin, expectorant. Expectorants, they are producing more fluids. You might lead suffocation of that infant if you give them more guaifenesin. So it's not recommended as well. Some people, they might see benefit from vitamin C, zinc, or echinacea in children for treatment or prevention of common cold, but we don't have enough data to support that use. The safety and effectiveness of these cold and cough medications in children have not yet been approved. In 2008, the US FDA issued a public health advisory recommending that over-the-counter cough and cold medications not to be used in children less than 2 years old. Therefore, absolutely no cough or cold medications below 2 years. The only thing they can use mist or normal saline nasal drops. So the treatment of cough and cold, normally, if deemed necessary by a physician for an older children, non-prescription cough and cold medications containing single ingredients. Normally, a lot of these medications, by the way, they have 2 or 3 substances. So they sometimes combine an antihistamine with decongestant, with a cough suppressant, or a mucolytic. So if you have more ingredients in one drug, then the medication error is normally high. Therefore, if it's a must to give a medication like this by a physician also, normally tend to give only a single drug, a single ingredient cough and cold preparation, because it has lower side effects and the administration is going to be easier than giving a multiple ingredients in the same product. طيب احنا عندنا الكويز بعد شويه، فانا بتوقف هون.